Kia ora, everyone. We are here today representing Gender Minorities Aotearoa, a nationwide transgender organization. It is run by and for transgender people, including binary and non-binary, intersex, and irawhiti takatapui. We operate within a kaupapa Maori public health framework, Te Pai Mahutanga, and the Ottawa Charter from 1986. Our aim is to facilitate health and well-being for transgender populations, as defined by the World Health Organization. My name is Maudlin, and I will be facilitating GMA's panel today on informed consent. And with me, I have Kate and Ada. Would you like to introduce yourselves?
Kia ora, I'm Adeline or Ada, and I work at Gender Minorities Aotearoa as a community liaison and also in resource development.
Kia ora, my name is Kate. I am also a community liaison at Gender Minorities Aotearoa. I do a lot of the face-to-face peer support at our gender centre, and I represent GMA on the Sex and Gender Diverse Working Group through the Capital and Coast DHB.
Great, thank you all for being here. As we are discussing informed consent, the first question that we'll be asking is, what is informed consent? Ada, would you like to speak to this?
Yeah, so in simple terms, informed consent is just a process where patients can demonstrate competency and understanding to make decisions about their own healthcare. In gender affirming healthcare, clinicians should listen to their patients' transition goals, inform them about their treatment options and the possible results of those options, and then allow them to consent to receiving that treatment if they want.
What do the guidelines say about informed consent?
The guidelines for gender affirming healthcare stress making sure that the patient is in a position to make their own decisions while respecting their autonomy and not subjecting them to pathologizing models of healthcare. The guidelines also specify that an important part of that process of depathologization is for trans people to be the ones to inform others about who we are and how we should be referred to. In addition, the guidelines specify that gender affirming healthcare procedures are medical necessities for transgender people, and they should be available and accessible.
Kate, would you like to tell us about informed consent in the law?
You're muted, Kate.
So in Aotearoa, the healthcare system is bound by the Code of Health and Disability Consumers' Rights. That means healthcare providers have both a legal and ethical responsibility to be aware of these rights and to exercise them. While this is a very extensive document, there are several aspects of it that are particularly relevant to our discussion today and gender affirming healthcare. So first of all, patients have the rights to be presumed competent to make their own healthcare decisions and to understand the risks and to consent to those risks. Providers have a responsibility to fully explain the options, including both the advantages and the drawbacks of each procedure. And it is also illegal to push or subject patients towards treatments that they don't actually want.
Thanks, Kate. Now we will cover why consent is sometimes neglected.
Sorry, I didn't hear that last word.
We're going to cover why consent is sometimes neglected. Ada, would you like to start us off?
Yeah, sure. So there's a long history of a kind of corrective medical tradition around trans healthcare. So Western medicine has a long history of prescribing ideas about what are correct gender and sexual practices, such as back when being gay was seen as being medically undesirable. In many places across the world in healthcare situations, someone turning out to be trans is seen as a worse medical outcome than not being trans. And that leads to all kinds of dangerous practices, such as denying people healthcare, keeping people on dangerously low levels of hormones, or trying to dissuade people from the outcome they desire if that outcome involves being transgender. And instead of this, healthcare professionals should be informing their patients of the actual possible outcomes and simply letting those patients consent to those outcomes if that's what they want.
Thanks, Ada. Kate, do you have anything to add?
The pathologized history of gender-affirming healthcare has distinct roots in those traditions of normalization. So in particular, influential clinicians like Harry Benjamin and Ray Blanchard devised a framework for the correct way to be transgender, which was both heterosexual and misogynist. Essentially, it stipulated that to be a real trans person, you had to be a trans woman, first of all, and you had to be available for sex with men, which is obviously not a very good framework for understanding what it is to be a woman, much less what it is to be truly transgender. So transgender who failed to meet those expectations for how a person of their affirmed gender should behave were denied treatment and also diagnosed with a sexual paraphilia disorder. And while those ideas are no longer the established framework for accessing gender-affirming healthcare, the legacy of deliberately limiting access to it still lingers. Even today, we still sometimes have people come to us talking about how they've had mental health professionals tell them or question whether they're truly trans, and apply that framework and tell them that they've got a sexual paraphilia disorder, that it's just a fetish, it's not a true thing, and they shouldn't have gender-affirming healthcare.
Thanks, Kate. I just want to add there that there's sometimes some presumed incompetency when doctors are dealing with patients, and that healthcare providers are experts on complicated subjects, and that there's usually an enormous gap in expertise between the clinician and the patient. But because of this long history that Kate and Ada just described, about restrictions on gender-affirming healthcare, the dynamic between healthcare provider and patient is often different in these circumstances. Transgender people often have to resort to doing their own research and relying on resources shared between others in the trans community. This results in trans people having higher levels of knowledge about gender-affirming healthcare. This healthcare is an enormous part of our lives, and that adds to the greater wealth of knowledge within the community as well. Despite all of this, providers often refuse to acknowledge or respect their trans patients' knowledge. What we see in gender-affirming care is often a one-size-fits-all model, which might work for some trans people, but if it doesn't, they have a really hard time finding a doctor who will respect them enough to take their views and experiences into account when providing treatments. Having respect and acknowledging your patient's knowledge and the research they've done, that comes under informed consent as well. Next, we'll be talking about what informed consent actually looks like in practice. So, Ada, can you give us some examples?
So one example would be doing an informed consent process to start hormone replacement therapy. And that would usually just involve that basic stuff of informed, so information, and then consent, so someone agreeing to it. So usually involves a list of, going through a list of the things that hormones can change, while also telling the patient which things can't be changed by hormones, especially where someone might have unrealistic expectations. And then if someone has some goals that hormones aren't going to change, discussion of other treatment options is appropriate, such as referral for medically necessary hair removal, voice training for trans women, or things like surgical options. And once you've done that, that information, then you can move on to the consent. Once those concerns have been addressed, it's up to that informed patient to decide which treatment options to pursue. And that's usually followed by a prescription.
Kate, do you have anything you would like to say about starting HRT and the informed consent process?
Yeah, sure. So we talk to a lot of trans people who come in to see us because they've got questions about starting HRT. They might also have questions for the clinician, but often we find that they have done a lot of research already, and we've produced some really good resources that help them understand what HRT can do and what it might not be able to do. But generally we find that their biggest concerns are getting started as soon as possible and finding the most effective treatment possible. So sometimes we hear from trans people that their doctors have questioned their validity, whether or not they're really trans, and ask them to take unnecessary steps to prove their transness. Often that involves being referred to a psychological healthcare professional who will do an analysis to find out whether or not they're truly trans. Sometimes it looks like trans people being forced to show to their doctors that they have the right support networks in place, or their doctors demanding that they take extra time to make sure that they have some sort of psychological support in place, when really what they need is just to start hormones and get on with their journey. Further to that, informed consent practices with starting HRT. In order to do the informing, it requires a fair bit of knowledge, quite specialized knowledge on behalf of clinicians. So they should either know or know how to find out the full range of hormones that are available in Aotearoa and be willing to prescribe them if the patient wishes. And often we find that the risks associated with hormones are overstated. And there are fears that the patient might regret the decision, which are elevated and not reflective in any of the data that's looked into that. Ultimately, though, it is the patient's decision as to what healthcare options they're going to take, which affects their own body. And then the responsibility lies with them too.
Thanks, Kate. Is there anything else that doctors should know when practicing informed consent? Ada?
So I'd say that the goals of the patient do have to be tempered with reasonable expectations as to what hormones can achieve. We're often asked by doctors how to deal with patients who won't accept the amount of hormones they're on, and patients really have to be trusted to manage much of their own risk profile when it comes to what side effects are acceptable or unacceptable, and that comes under that informed consent process. So many doctors are very reluctant to raise trans women's hormone levels to levels that are common in cis women, or will want to reduce trans women's testosterone to very low levels before allowing increases in estrogen. And this is usually done completely without the patient being appropriately informed of the high risk posed by insufficient sex hormones, which include things like bone density collapse or organ atrophy, or the very serious risk that's posed to trans people by having doctors who are failing to raise their estrogen levels to a level where they'll have an effect on that person's body. So you get people on doses which aren't doing anything to them, or could be actively harming their body in very bad ways. And you'll often find that trans people know more about what these risks are than the doctors who are refusing to prescribe them their healthcare.
Kate, do you have any examples?
Yeah, I'd like to talk about progesterone, which is a topic that drives a lot of tension between transgender patients, trans women, and their doctors. While research shows that progesterone is a vital hormone in the development of breast tissue in cisgender women, there is little research about its effects on the development of transgender women, and what research that has been done has been inconclusive. Doctors often see this as a reason why their patients should be denied progesterone, even when in the majority of the cases, patients are fully competent to understand that the evidence is inconclusive and make this decision for themselves. Often the biggest issue for the patient in having a prescription for progesterone is just the cost. It should be on them to decide.
I'll just quickly speak to another thing that we frequently hear about at GMA, which is puberty blockers. We get a lot of questions about puberty blockers and how to prescribe them, and what the long-term health effects are for puberty blockers. Many of these questions come from parents, but we also get doctors and clinicians wondering. And I think that it's helpful for puberty blockers to compare it to birth control and the Gillick competency model, which is used to prescribe birth control to underage people. I think this is a comparable model, firstly, because puberty blockers and birth control both fit into important harm reduction frameworks, despite being like intensely politically controversial topics. Secondly, I think this is relevant because in both cases, a parent who thinks they can or should control their child's gender or whether or not their child is having sex, that's a direct contributor to the potential for harm. So we see when even people who are underage have full access to the information, to possible outcomes, possible side effects, that they are able to make these decisions for themselves, that the outcomes are positive, they're beneficial, they prevent more harm in the long term, and that is ultimately our goal. Next, we will just cover, does informed consent relate to other gender affirming healthcare like surgeries? And we're going to talk a little bit about what that looks like, with Kate starting us off.
Cool. So we do understand that often primary barrier to offering surgical pathways for gender affirming healthcare in Aotearoa is one of capacity. Trans healthcare has been neglected in Aotearoa and neglected internationally. And we've talked a little bit about why that is and what the history behind that limiting the access to gender affirming healthcare looks like. But also we see that when surgical pathways are available, we still hear clinicians are overlooking transgender patients for gender affirming surgeries in the enduring belief that it's low priority. So we just want to echo the statements in the guidelines for gender affirming healthcare. These treatments, these procedures are necessary medical treatments, and they must be available in order for the patients to have that autonomy over their body, in order to be able to choose the right gender affirming healthcare procedures for them. They need to be available in the first place. And we see that a lot of them really aren't. And even in DHBs where people have pulled together to try and create pathways to these surgeries, the capacity just is completely unable to meet the demands, and it's not a sustainable system.
Thanks, Kate. Is there anything, Ada, that you would like to say about informed consent around surgical pathways?
Yeah, I would add to what Kate said about the fact that a lot of these pathways don't exist, or that they're hard to access for various reasons, but also that currently trans people are severely underinformed about the existing pathways. So we have an issue not just with the existence of options, but also the access to the information about those options. That's often the case because the doctors also lack that knowledge and don't necessarily make an effort to find it. It's hard to practice informed consent when that informed part is so inaccessible. So trans people trying to access surgery are usually doing their own research, finding the obscure places online that describe what those pathways are, and then having to work with a willing and helpful doctor who also is usually not informed about these pathways, all just to figure out how to even access those waiting lists in the first place. And furthermore, trans people are often not trusted to give consent to surgical options that might change their reproductive capabilities. We're treated as though we can't be trusted to choose our reproductive future for ourselves. It's the case where clinicians are often very insistent that we have to go through some process of sperm preservation or anything like that before we're able to access these surgeries, despite the fact that we might be perfectly competent to consent to them. Another issue is that the prioritization tools that are used for these things at the moment are looking for high levels of psychological distress. So that's the tools for the waiting lists, basically, for prioritizing who gets surgeries first. And the problem with that is that a model that requires you to be in distress to access necessarily healthcare can only increase those rates of psychological distress. You know, if you set a limit that we're going to wait until people are having this much of a bad time before we'll help them, well, then everyone's going to have a bad time.
Those are some good points. I think we can just end on the question, can you think of some examples of good informed consent? And I will give this one to Ada as well.
Cool, thank you. Yeah, I suppose we've been talking about some of the negative aspects of how informed consent's been practiced, but also some of the ways in which it could be better. But some of the positive changes that have been going on include things like how trans people are currently conceptualized in the DSM, the Diagnostic and Statistical Manual, which reflects a positive trajectory towards an informed consent model. Initially, as we spoke about, being trans was seen as a disorder, and gender affirming healthcare was seen as treatment. And this framework has deeply influenced the issues for trans people accessing gender affirming healthcare that we've discussed. So the move in the DSM from gender dysphoria towards a definition of gender incongruence reflects that for some trans people, their body is not always a source of distress, but simply that they know who they are for themselves and they know what they need for their gender from gender affirming treatments that clinicians are able to provide.
Right. And we hope to see more positive effects of properly implemented informed consent in the future. Thank you both, Adeline and Kate, and thank you all who are watching. This will conclude the end of the pre-recorded presentation section of GMA's panel. After this, we'll be moving to the final section for question and answer.
Thank you, Maud.